Hello, and welcome to the CAP Today webinar for Thursday, July 29th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session at the end of our webinar today. Today's webinar is entitled Measurable Residual Disease by Multiparametric Flow Cytometry in Acute Lymphoblastic Leukemia. And our webinar today is sponsored by Amgen, and we wish to acknowledge Amgen and thank them very much for their support in bringing you this important program. Our speaker today, and I'll say more about him shortly, is one of the most distinguished experts in this field. Dr. Brent Wood is currently at the University of Southern California and the Children's Hospital of Los Angeles, and as I say, I'll say more about him when I introduce him shortly. But first, I want to share some housekeeping tips, as I always do. We recommend often that you refresh your browser. That can help optimize your enjoyment of today's program. LiveAid is always available throughout today's presentation. You'll see an 888 number on the lower right-hand corner of your screen. You can call that, and we have folks at hand ready to help you with any questions or problems that you have. To the left of that phoning box, you'll see questions and answers, or Q&A, beneath the slides. You can ask for technical help by typing in there. And again, live people will come and help you. But of course, principally, that box is for you to ask your questions or make your comments, and you can do so at any time during today's webinar. When Dr. Wood finishes his presentation, then we'll take all of your questions and comments in the time that we have available, and we hope to have a vigorous discussion and answer your questions. In a few weeks, we'll be posting all the slides and audio of today's presentation. You can find that at captodayonline.com. I want you to know you're likely to see a follow-up email or two, and so please be advised of that. It's perfectly legitimate. Lastly, and the last of my tips, is that it's important that you know that CAP Today does not endorse any products or services that may be mentioned today. And also, any comments that I make are purely personal, not to be taken as the policy of CAP Today or the College of American Pathologists. And now, let's turn to our program, and it's my special privilege to present Dr. Brent L. Wood. Dr. Wood got his PhD at Loma Linda University and then spent 30 years in Seattle at the University of Washington with a very distinguished career, as you all know. Within the last year, he's come to the Children's Hospital of Los Angeles and the University of Southern California, where he's the director of Hematopathology and a full professor, of course, of Pathology and Laboratory Medicine at USC. Now, before I ask him to begin, I do want to read for you some program information that Amgen and I both think it's important for you to know. This program is being presented on behalf of Amgen Incorporated, the sponsor of this program, and has been reviewed consistent with Amgen's internal review policies. This is an educational presentation and is not intended to promote Amgen products or any other product. Further, it should not be construed as a representation that any specific therapy might be safe or effective at treating any particular disease. This presentation is not a CME accredited program, and you should know that the speakers in such programs from Amgen have been compensated for their participation in the program. And with that now, it's my enormous pleasure and privilege to present to you Dr. Brent Wood, and he'll now deliver his lecture. Dr. Wood.
Thank you so much, Bob, for that very kind introduction, and greetings from sunny and beautiful Southern California. I'm happy to be with you today to talk about minimal or measurable residual disease testing by flow cytometry in lymphoblastic leukemia. For this talk, the objectives and the agenda are outlined here. We'll talk a little bit about the background of MRD testing, and then focus on flow cytometry in terms of its methodology, special considerations that apply to flow cytometry in this context, and how we analyze data and report flow cytometry results. Finally, we'll talk about the clinical decision-making that's performed using MRD results and illustrate that with a couple of case studies. So in terms of background, MRD, or measurable residual disease, has turned out to be one of our strongest prognostic indicators in B lymphoblastic leukemia, or what we call historically BALL. And MRD is defined as the presence of detectable leukemic cells below the level of detection that can be seen by morphology historically. These days, that generally refers to a level of detection that's down around the level of 0.01% or 1 cell in 10,000 within the bone marrow. And this is typically done after initial induction and consolidation chemotherapy, so during remission. A variety of studies, some of which we'll discuss briefly today, show high prognostic value of MRD both during and after initial induction therapy. And there's a strong association between the presence of MRD and the relapse risk the patients have following therapy. In particular, patients that are proceeding to bone marrow transplantation with MRD positive disease often have a higher relapse rate than patients where there's an absence of detectable disease. And on the left-hand side of the slide, you can see a representation of a number of the different paths that patients may take during the course of their disease following therapy. Usually at the beginning of treatment or prior to treatment, there's a large number of leukemic cells that are present in the blood and bone marrow, as depicted on the left. And as therapy is delivered, the number of leukemic cells hopefully will decline. And this happens at a variable rate for different patients, depending upon the responsiveness to the therapy that's being employed. For some patients, as depicted on the bottom curve, there's a relatively complete response, and the leukemic cells disappear, never to be seen again. Whereas for other patients, they remain present at some detectable level that's dependent upon the technology that's employed and the level of disease that the patient has. Those patients are at an increased risk of relapse and are patients in whom we might want to intervene at an earlier stage in order to improve their eventual outcome. And that's one of the primary purposes of performing MRD testing, is to allow for these types of modifications of therapy so patients' outcomes can be improved. It's important to realize that historically, since we've used morphology as the way to assess complete response, that patients who achieve a complete response or a CR may still have detectable residual disease. So if you look at patients with BALL in general, in which multi-agent chemotherapy is typically delivered, by morphologic assessment, 85 to 92% of patients will reach a CR. And so it appears that the disease has been at least significantly reduced, if not eradicated. But if one applies more sensitive techniques, such as flow cytometry or, as is shown on this slide, molecular assessment, you can demonstrate that a significant number of those patients, between 30 and 40%, still have detectable residual disease after therapy, even despite the absence of apparent morphologic remission. And so these patients are relatively high in number and are patients that then form the basis for the potential for an increased risk of relapse, for which we might want to intervene. This is now recognized as an important prognostic factor to the extent that the NCCN has incorporated MRD testing into their clinical practice guidelines for oncology. And for both adult and pediatric ALL, the recommendation is that MRD testing should be performed with using the first small volume pull of bone marrow, small volume here being described as less than 3 milliliters, and we'll talk about the rationale for that in a little bit. If the patient is not treated at an academic medical center, then commercially available tests are available from either large commercial laboratories or from other commercial providers, and these should be used for MRD assessment. The idea here is that one uses a laboratory that has enough experience performing this type of testing that they can do this in a reliable and reproducible manner, hopefully in a well-validated assay. MRD testing is also recommended to be performed at the end of induction chemotherapy, so after the most intense period of therapy, whether this is for de novo or relapse disease, and then again at the end of consolidation therapy to assess the response to the entire therapeutic block. Past those time points, one needs to follow the appropriate treatment protocol or testing regimen that's recommended for further testing. What's most important is that testings be performed both at the end of induction and at the end of consolidation therapy. Serial monitoring may be increased in patients where there's an increased concern for relapse, for instance, patients that have detectable disease by molecular methods or other sensitive technologies. In addition, it's important to assess the presence of disease prior to giving the therapy and establish a baseline, either using flow cytometric or molecular techniques, to identify the features of the leukemic population that can then be used to help identify that population after therapy. In the case of molecular methods, this means identifying a sequence which can then be monitored as a leukemia-associated or specific sequence after therapy. In the case of flow cytometry, this means identifying immunophenotypic features that differ from normal that will allow us to distinguish those leukemic cells from normal B-cell precursors in the marrow. The reason this is being done is that MRD positivity at the completion of induction therapy does predict for a high relapse rate and should prompt evaluation for additional more aggressive or different types of therapies such as allogeneic bone marrow transplantation. In principle, the intent of all of this type of therapy is to eradicate the presence of leukemic cells, and this means eliminating MRD prior to going into bone marrow transplantation. There have been a number of studies over the years that have been performed using a variety of technologies and a variety of different contexts looking at the clinical significance of MRD, and these were recently summarized in a very large meta-analysis that was conducted and published in JAMA Oncology. For adult patients with B-lineage ALL, for both event-free survival on the left and overall survival on the right, it's quite clear that the presence of MRD or MRD positivity is correlated with decreased survival or decreased EFS, whereas the absence of MRD is associated with a much better clinical outcome for both EFS and overall survival. This is also true for pediatric patients, where an even larger number of patients have been studied, and there's been a much more robust data set collected over the years. But both for EFS on the left, event-free survival, and for overall survival, OS, on the right, there's a clear association between the presence of MRD and reduced survival or a poorer outcome, whereas the absence of MRD is associated with better outcome. So at this point, there really is no doubt that the presence of residual disease detected after therapy is associated with worse outcome. And I think everyone agrees that this is the case, and hence is the impetus for advocating for the testing for residual disease as a routine clinical practice. If one looks at a variety of different factors that are associated with the performance of MRD testing, such as the disease stage or the time when the testing is performed, the level of disease that is detected or can be detected by the technology used, the risk group, the testing location, the timing of testing, etc., in all cases, the presence of MRD, or said the other way, the absence of MRD, is associated with better clinical outcome. And you can see that on this forest plot where all of the data points are shifted to the right of that dotted line, indicating that their association with better outcome with hazard ratios. So essentially, no matter how you do it or when you do it, if you detect residual disease after therapy, it's a bad thing. And so the goal here is to eradicate the presence of residual disease. If one looks at the different methodologies that have been employed for detecting residual disease, they fall into three basic categories at this point. The first of these is flow cytometry, which we're talking a bit about today. In flow cytometry, we are trying to detect the presence of leukemic cells by looking for differences in immunophenotype from those seen on normal cells of similar type, in this case, B-cell precursors. These differences are often referred to as leukemia-associated immunophenotypes, but it's important to recognize that these immunophenotypic differences can change after therapy and don't necessarily remain static. So you can't rely very strictly on the preservation of a particular immunophenotypic abnormality over time as the patient delivers therapy. But in aggregate, these can be used to monitor and identify in a reasonably sensitive way the presence of residual disease. The sensitivity of these techniques ranges from about 0.1% to 0.01%, or 1 cell in 10,000 for simpler methodologies such as 3 or 4 color flow cytometry, and can be increased to a level of sensitivity around 1 cell in 100,000 or 10 to the minus fifth if one uses more sophisticated panels of reagents and collects larger numbers of events, as we'll talk about in a little bit. The benefits of this technology are that it's very rapid, and so in principle, one can get a result on a sample within a few hours after receiving the sample. But one of the limitations is that there's a lack of standardization as to exactly how this is done, and depending on how it's done, there may be some limitations in sensitivity. In addition, it's an interpretive assay at its root. It requires a trained individual, such as a pathologist, to review the flow cytometry data and to issue an interpretation, and that introduces some subjectivity that can be difficult to standardize as well. And so it requires a person with sufficient experience and training in order to accurately perform this assay. Another technology that's commonly employed for detection of MRD for lymphoid neoplasms is PCR-based technology. This has been around for some time, and this takes two different forms. One of them is the detection of abnormal gene fusion, such as the BCR-ABL translocation, using a real-time qPCR-based approach. The other is to look for specific rearrangements of the immunoglobulin or T cell receptor genes that occur during lymphoid development. And as lymphoid cells develop, each cell develops a unique set of rearrangements of those genes, which can then be used as a leukemia-specific marker, given that leukemia is a clonal expansion of initial single cells. These types of technologies are capable of sensitive detection of MRD down to a level of about 10 to the minus 4 or 10 to the minus 5, and they can be both highly specific as well as highly sensitive, and can be performed in a relatively standardized way, as the European groups have shown. There are a few limitations with these types of approaches. When one's looking at fusion proteins such as BCR-ABL, it's possible that these fusions are present not just in the leukemic cells, but in precursor or pre-leukemic populations of cells that may then persist after therapy. And so in a sense, you get false clinical positivity for some subset of patients after therapy. And there's always the risk of cross-contamination when you're using any kind of highly sensitive assay. For the ASO PCR assays looking at sequences of the immunoglobulin and T cell receptor genes, these are relatively time-consuming assays because at the time of diagnosis, one needs to identify and sequence these loci to get the initial sequence, develop patient-specific primers, validate those primers, and have those ready to go within about a month to assess the end of induction samples. And that's a lot of work, so it tends to both take time and be relatively expensive to generate these patient-specific primers. And so as a result, they've been primarily used in large clinical trials in Europe, and are not as commonly used at this point in North America. A variation of this technology has been developed for next generation sequencing or high throughput sequencing, and here called NGS. It utilizes the same principle as ASO PCR based assays, but because of the high level multiplexing that's capable for NGS, one can create families of primers that can amplify all possible combinations of the genes at these particular loci, and develop an assay that doesn't require the specific creation of patient-specific primers that's required for the ASO PCR assays. Instead, can have a very standardized assay that can be performed on the large majority of patients, particularly with B-ALL. It's been shown that this type of assay is highly sensitive, doesn't require patient-specific primers, uses the patient's own sequence for detection of the leukemic sequence, and is now available via reference labs, including one that's been FDA cleared. The one disadvantage of these types of assays, in addition to requiring access to pre-treatment material to get the leukemic sequence, is that the turnaround time is still relatively long. It's something around 7 days or a little bit longer. But nevertheless, this is an up-and-coming technology that's being increasingly employed for the detection of MRD. So given these options for detection of MRD, let's talk a little bit more specifically about flow cytometry today, and we'll leave the molecular methods for another time. If one looks in pediatric and adult B-ALL in the United States or North America, what one sees is that on the right, in pediatric contexts, flow cytometry is the dominant technology that's used for MRD detection. This in part reflects the choices that were made by the Children's Oncology Group a number of years ago to pursue the use of flow cytometry rather than PCR as the method for MRD detection, and that's kind of penetrated into the pediatric institutions in this country. So 85% of the testing is done by flow cytometry. Increasingly, there's a larger component of next generation sequencing that's being employed, and so that number is now changing. But nevertheless, flow cytometry historically has been the major method used for pediatric patients. For adult patients, the situation has been much more mixed, in part because the adult oncology groups are less standardized than the pediatric groups. And so flow cytometry is used for almost half of those patients, the rest being made up by a combination of PCR, next generation sequencing, and other types of technologies. But as for the pediatric patients, the use of next generation sequencing is rapidly increasing, and so that is being more commonly used for the assessment of MRD. So in the US, flow cytometry still plays a major role in the detection of MRD. However, if one looks at Europe, because of the way technologies developed there and their ability to employ molecular methodologies in a standardized way, real-time quantitative PCR is a more commonly used technology, particularly in European MRD clinical studies, and flow cytometry there plays a somewhat more secondary role. So there are differences between North America and Europe in terms of the technologies that have been historically employed. So how does flow cytometry go about detecting the presence of these residual leukemic cells? Well, one of the basic principles of immunophenotyping to detect cancer or malignancy is that one needs to look for immunophenotypic differences from normal precursors of similar type. This means looking at the expression of abnormal cell surface markers or antigens on the leukemic cells in a way that's different from what's seen on normal precursors. To do this by flow cytometry, we take a single cell suspension that's pictured on the left. We stain that with a panel of antibodies, usually monoclonal antibodies that are coupled to a variety of different fluorochromes and a panel. That suspension of stained cells is then introduced to a flow cytometer where it passes through the flow cytometer one cell at a time. One or more lasers are used to then illuminate the fluorochromes and to measure light scatter on the cell populations, one cell at a time as they go through the instrument, and develop a data file which contains a multi-parameter data set for representing the expression of each of the proteins of interest that was labeled using those antibodies, along with their associated light scatter properties. As a result, this is relatively complex data and requires someone with expertise and training to be able to interpret that data. And as a result, this can be difficult to standardize, not unlike trying to standardize morphologic evaluations. It's an interpretive assay performed by a trained professional. There still remains a fair bit of variability in terms of the immunophenotyping protocols that are used, the antibody panels that are selected, the data analysis or gating strategies that are employed between different centers. Although we have made some progress, I would say, in the US, particularly in the pediatric realm, by disseminating the Children's Oncology Group BALL MRD assay in a standardized way through a validation process to now more than 30 different major laboratories. And so there's some degree of standardization that's been achieved, particularly among the standardized protocols and interpretive components for that particular assay, but there is still significant variability that remains in general in this field. In addition, once the assays have been validated and established, there needs to be ongoing proficiency testing to allow laboratories to assess their own performance. And at the moment, these proficiency testing programs are still relatively rudimentary and require some further development to really fulfill that role. In terms of some of the details of the flow cytometry assays that are employed, there's a necessity to use a complex enough panel of reagents that is sufficiently informative that it can distinguish abnormal cells from normal cells. And this means these days using at least 6 different fluorochromes or colors in such a panel that's designed. This really allows for a sufficiently informative assay to distinguish normal from abnormal. So these types of standardized flow-based assays, such as the Children's Oncology Group assay that I mentioned, have allowed some degree of standardization and development of assays that can detect residual disease down to a level of about 0.01% in a very consistent fashion in bone marrow, particularly at early time points after therapy, where the number of normal B-cell precursors is typically very low. These assays have not been as rigorously tested in samples that are further from therapy, such as end of consolidation or even further out, where the number of normal B-cell precursors is typically increased during regeneration. And so more work needs to be done to further define the performance of these assays and to increase their sensitivity at these later time points. The acquisition of more cells, particularly in a higher level multicolor context, such as at least 6 to 8 color flow cytometry, can improve the sensitivity of the assay by up to essentially 1 log, as we'll talk about in just a minute. And again, the detection of MRD in this context is being done to inform decision making, so decisions can be made about the necessity of additional therapy or modifications in therapy to clear or remove whatever remaining leukemic cells might be present. But it's important to use a panel of reagents that's sufficiently informative that one can make this distinction of normal from leukemic cells. To emphasize the point, or the importance of collecting sufficient numbers of cells on the instrument, this is some data taken from one of the Euroflow publications, where they've created an assay that's able to detect down to a level of 0.001%, or 1 cell in 100,000, reasonably consistently. That's largely matching the sensitivity of standard RT-qPCR assays. And this is done in part by using a sufficiently informative antibody combination of 8 colors with a couple of different tubes, and then collecting a large number of events, up to 5 million events. And what is shown in this slide is that as one increases the number of cells or events that are acquired on the flow cytometer, the ability to consistently or reproducibly detect the presence of residual disease can improve. Now, this depends a little bit on the criteria that are used to call a population positive. In this particular study, they were using a criteria of requiring 40 cells in the leukemic population in order to call something leukemia. And at that level, one does require an even larger number of cells in order to reproducibly identify 40 cells in the leukemic population. If one can detect cells with fewer events, say 10 or 20 cells in the leukemic population, which we commonly do in the Children's Oncology Group assays, the number of cells that be required may be somewhat lower. But nevertheless, it makes the case that you need to acquire at least 1 million cells in order to achieve consistently a sensitivity of 0.01%, and a somewhat larger number of cells, maybe up to 5 million cells per tube, in order to get a sensitivity of 0.001% using a sufficiently informative panel of reagents, in this case, an 8-color flow cytometric assay. So collecting an appropriately large number of events is important to achieve consistent high sensitivity. Another important variable that will determine the quality of the study and the reproducibility of enumeration for this type of assay is to make certain that we have a high-quality sample that truly represents marrow when we do this testing. And so as a result, what's been advocated for is that the first pull of the bone marrow aspirate be used for MRD testing, since this is one of our strongest prognostic factors and is increasingly driving clinical decision-making. The MRD quantitation is highly sensitive to the presence of contamination from peripheral blood or hemodilution, because typically there are fewer leukemic cells in blood than marrow, and so as one introduces increased amounts of peripheral blood, you dilute out the leukemic population and can underestimate the level of residual disease. And this can be significant in a subset of cases. And so using the first pull of bone marrow provides the highest assurance that you're looking just at bone marrow and that the enumeration that's provided is as accurate as possible to assess the disease burden that's present in the bone marrow. To illustrate this, in a recent study, about 30% of analyzed bone marrow specimens had significant levels of hemodilution. And here hemodilution is assessed using flow cytometry, measuring the relative proportion of CD16 positive neutrophils of total myeloid cells in the sample. And so they were able to, in a relatively quantitative way, identify that significant numbers of bone marrow samples contain relatively high levels of peripheral blood contamination or hemodilution. The impact of this is illustrated by another study where it was found that pulling a second pull of marrow results in a significant hemodilution that can underestimate the level of MRD and drop it below a clinical decision-making threshold, leading to negative results as a result of simply hemodilution. So as a result, the NCCN guidelines recommend that one uses an initial pull of less than 3 mL of bone marrow in order to minimize hemodilution so that one gets accurate MRD quantitation to the extent that's possible to allow the most accurate clinical decision-making. And so increasingly, laboratories are encouraged to, rather than just sending the first pull entirely for morphology, to at least split that first pull for whatever MRD testing is being performed, such as flow cytometry or molecular methods, in order to allow for the best enumeration and hence the best clinical decision-making. There are some special considerations that we should talk about relative to flow cytometry beyond just the acquisition of sufficient numbers of events and using a highly informative antibody combination. One of these is that we now live in an era of immunotherapy, and so many of the antigens that have relatively high specificity for identifying these leukemic populations of interest are also now immunotherapy targets. And this includes CD19, which is one of our principal antigens that historically is used to identify B cells. Because of its specificity and its ubiquitous presence on B cells, it's become an initial attractive drug target for B cell malignancies in general and for B lineage ALL in particular. And so as a result, a number of therapies have been developed that target CD19, and as a result of targeting CD19, this can cause a downregulation of CD19 or an absence of its presence on the cell surface in a way that can make the detection of MRD more difficult and can also lead to relapse that may be, in fact, CD19 negative. The possible mechanisms for this decrease in CD19 expression are increasingly understood. One of these is just a downregulation of CD19 itself, and part of this is a change in the splicing of CD19 to remove one of the epitopes where the antibodies or the targeting is typically performed. But in either case, it downregulates the detectable presence of CD19 on the cell surface and can then create difficulties in identifying B cells after these therapies have been used. It can then allow the expansion of CD19 negative clones in this context, which can then lead to relapse, and there are also disruptions in the transport of CD19 itself within the cell. As a result of the impact of these therapies, modifications to the standard approaches that we've used for these flow cytometry MRD assays are necessary, and one needs to rely on antigens other than just CD19 for the identification of B cell populations for assessment. One of these approaches that has been described utilizes alternative B cell antigens such as CD22 or CD24, but it has to be recognized that neither of these antigens has the same high degree of specificity as CD19 for this purpose, and so one needs a relatively sophisticated integrated strategy in order to do a really reproducible and high quality job in identifying MRD in this context. So the presence of immunotherapy does challenge the ability of flow cytometry to reproducibly detect MRD unless adjustments are made to the existing assays. The other consideration that we've kind of alluded to is the necessity of the ability to distinguish leukemic B cells from normal B cell precursors. And so one needs to design a panel of reagents that is specifically informative in order to make that kind of distinction. And that's depicted here on this slide, where in panel A on the left, we have a map of normal B cell development using a variety of different antigens. And on the right, there's the addition of a population of leukemic cells at the time of diagnosis or pretreatment that's in dark blue, which shows differences in the levels of expression of a variety of these antigens from what's seen during normal B cell maturation. And so as one develops these types of assays, panels of reagents need to be developed that allow for this type of recognition or distinction of levels of expression of antigens that are different from those seen on normal B cell precursors. And it's this distinction of normal B-cell precursors or hematogones from leukemic blasts is one of the principal challenges in using flow cytometric or immunophenotyping-based MRD assays. Similar challenges exist for morphology in distinguishing benign early B lymphocytes from leukemic blasts, and that's one of the reasons why these flow cytometric approaches were originally developed. If one uses panels of reagents that are relatively simple with just a small number of reagents, say a low number of fluorochromes or antibodies in the panel, they may not have enough informative content to reliably distinguish these normal B-cell precursors from leukemia, and the result can result in either lower sensitivity assays or an inability to detect MRD for at least certain subsets of patients, and hence generate false negative results. So the use of informative panels of reagents that distinguish leukemia from normal is really a prerequisite to doing this type of work by flow cytometry. In terms of data analysis and reporting of flow cytometry, as we've mentioned, the interpretation of this type of data requires an experienced interpreter to look at a series of dot plots and make a determination as to whether a given group or cluster of events represents leukemic cells. That information then needs to be converted into a form that allows for appropriate medical decision making. And here we present a somewhat schematized and very simplified version of a flow cytometry report that emphasizes the important components that need to be present in a flow cytometry report. Certainly on the left, we need patient demographic information in order to know who this sample came from and what type of testing was being performed. Knowing the specimen type, whether it's blood or bone marrow, is very important. Mentioning sample quality issues that may be identified, such as low cellularity, decreased viability, high degrees of nonspecific binding, may be important things to recognize if they negatively impact the ability to interpret the data or provide accurate quantitation. It's also important to recognize the time point of sampling that the sample was obtained from in order to allow assessment of the level of MRD relative to the normal counterparts that would be expected at that particular time point. So for instance, during active bone marrow regeneration at the end of consolidation, the number of normal B-cell precursors are typically increased. This tends to be less of an issue at end of induction. And so knowing something about the time point can be very helpful in assessing how well the marrow is actually responding to the prior therapy. Of course, once one does this type of analysis, what one really hopes to provide is an assessment as to whether or not residual disease is detected, and if it is detected, to quantitate that in some way so it can be used to describe the level of disease that's present and impact decision making. And so a result such as, in this case, 0.2% of abnormal immature B cells was identified because of an abnormal expression pattern of CD19 and CD34 is colored in blue, where the level of CD19 is abnormally increased on these CD34 positive progenitors, but there's also presumably other information that's present in that same combination that's helping to support that diagnosis. But as a result, we could identify and quantitate that population and then report it as a numerical value. We can also then describe the immunophenotype that's identified, and in particular, the things that are abnormal about that immunophenotype that are allowing us to identify this as something that is abnormal, such as the increased CD19 and the decreased level of CD34 in this particular case. We should also describe the methodology that was used. In this case, it's a simple 4-color flow cytometric method. And we should also mention the validated limit of quantitation or detection that has been documented for this particular assay. In this case, a level of 0.01%. So having gone through these technical issues, how do we use this information then to make clinical decisions based on MRD results? Well, I think it's quite clear that there is clinical utility in performing MRD testing, which is why we're talking about it today, in that high or persistent MRD levels after induction therapy can be used to identify patients, either pediatric or adult, who may require more intensive therapy or a switch to more novel types of therapy to improve their eventual outcome. One illustration of this is a study that was performed looking at a relatively large number of patients, about 500 pediatric patients with newly diagnosed BALL. And the MRD level was then prospectively used to guide treatment in a risk-directed fashion. So MRD was measured during and after induction therapy, and this was then incorporated with other clinical parameters to create a final risk status. Patients that had MRD levels greater than 1% were then given additional therapy in comparison to those patients that did not have MRD at that level who were not given additional therapy. And so as a result, they're modifying or intensifying therapy based on the presence of relatively higher levels of MRD. This resulted in significantly different event-free survival or outcomes for patients that had different levels of MRD compared to what was seen with the original risk classification scheme. So this is an example of using MRD to adjust risk classification and hence therapy and modify the patient's eventual outcome. This type of approach was also used in the UK ALL 2003 trial for both pediatric and young adult patients who were either standard or intermediate risk B-ALL. And these patients who were high risk MRD positive at the end of induction therapy were randomly assigned to receive either standard therapy or an augmented therapy where additional chemotherapy was delivered. And within this group of high risk patients, the event-free survival or EFS outcomes were notably improved for those patients that had received augmented therapy compared to what they would have received without that therapy historically. And so this type of risk-adapted approach to changing therapy based on MRD is increasingly being employed, particularly in clinical trial designs, in order to improve the outcomes for particularly high-risk patients. So let's look very briefly at just a couple of case examples to show how this might be employed. So in our case study number 1, we have a 3-month-old infant who has no significant medical history and presents with a poor appetite and swollen glands. The complete blood cell count shows pancytopenia with a large number of blasts, about 60% on peripheral smear review. And flow cytometry confirms the presence of an immunophenotype that's very typical of B lymphoblastic leukemia that occurs in infants, being an absence of CD10 expression and the presence of some myeloid antigens, in addition to the expression of CD19. As one might expect, the presence of an MLL rearrangement or KMT2A rearrangement is identified, as is common in infant ALL, and so the patient was started on therapy with a standard protocol. At the end of therapy at day 28, there was no evidence of residual disease, but 90 days post-transplant, the patient started to become positive for MRD based on flow cytometry. There was no information provided about the diagnostic immunophenotype at the time. The MRD assessment was performed just using our knowledge of what normal differentiation and expression patterns are of antigens for normal B-cell precursors compared to the populations identified in this sample. So what this in part illustrates is you don't need the diagnostic immunophenotype necessarily to detect the presence of MRD, provided you know what normal looks like. MRD positivity then manifested more overtly as relapse about a month later, and then greater than 50% blasts were seen by morphology. And this is an example of what that data looks like, where in red you see normal B-cell maturation that's been outlined, and this particular sample has a very nice demonstration of normal B-cell development from immature cells that have a high level of CD10 and an absence of CD20 in the panel on the upper left, as they progressively lose CD10 and gain CD20 to become mature B cells on the bottom right of that same figure. There's a population of cells, however, in green that's very different from those populations that lack CD10 and CD20 in the bottom left corner of that dot plot in the upper left, and that population represents residual disease. The only normal population of B cells that has that kind of phenotype are plasma cells, and those are pictured in yellow where the arrow is pointing in a few of the other dot plots. And so this is the appearance of MRD in flow cytometric data for what's usually considered a somewhat more difficult immunophenotype to assess MRD on, the CD10 negative variants of ALL that are very common in infants in particular. So some of the take-home points from this is that at 3 months post-transplant, as we saw, there is very robust marrow regeneration going on with a large number of B-cell precursors. So simplified approaches to identifying residual disease by flow cytometry aren't going to work as well, and an appropriately informative panel of reagents is necessary to identify these. In addition, as we alluded to, the diagnostic immunophenotype was not required to identify the presence of this population. We had an understanding, given that this patient had a KMT2A rearrangement, what the likely immunophenotype would be, and using an appropriately designed panel of reagents in a consistent way, we were able to confidently identify the presence of this abnormal population without detailed knowledge of the pretreatment immunophenotype. And so the use of an adequate or informative panel of reagents allowed for the confident demonstration of MRD, even in a background containing relatively large numbers of normal B cell precursors or hematogones, mature B cells, and plasma cells. Case study number 2, we have a 7-year-old girl that has multiply relapsed B lymphoblastic leukemia. This patient was treated with an anti-CD19 therapy, in this case anti-CD19 CAR T cells, and the bone marrow 6 months post-therapy showed MRD positivity by flow cytometry. But the leukemic population that was identified was negative for CD19. So at the time prior to therapy, CD19 had been expressed, which is why an anti-CD19 therapy was chosen, but now the relapse is coming back, showing an absence of CD19, along with other immunophenotypic abnormalities, such as decreased expression of CD38 and CD45. Again, no specific information was provided regarding the diagnostic immunophenotype to our laboratory when this testing was performed. We essentially just performed this analysis using knowledge of normal maturations of B cells and a sufficiently informative antibody combination. Subsequently, the patient then more frankly relapsed with CD19 negative leukemic cells. Here's an example of what that data looks like. And here we have normal maturation that's described in green, and there's a population of cells in kind of aquamarine or blue that represents the leukemic population. And on the top row on the far right, you can see that population fairly distinctly as a population expressing a high level of CD10 that's equal to or greater than that of the other normal B cell precursors in green just above that, but it lacked entirely the expression of CD19 as a secondary consequence of the use of this anti-CD19 immunotherapy. This population also shows downregulation of CD38, as is seen in the bottom row on the center panel, where that same aquamarine population shows expression of CD10 with essentially little to no CD38, compared with the normal B cell precursors, which express a predictably intermediate to high level of CD38 just to the right. So the take-home message is here is that the use of anti-CD19 therapy, such as, in this case, CAR T cell therapy, can lead to a loss of CD19 expression on leukemic cells, and so the leukemic cells can appear CD19 negative. And this can complicate these kinds of assays unless they're appropriately designed and implemented. In this case, flow cytometry detected the presence of the CD19 negative leukemic blast population as consistent with MRD because of the use of sufficiently informative and validated assay. But it required a different type of assay than what would have normally been employed for simple post-induction chemotherapy MRD evaluation because of the use of these anti-CD19 therapies. So it requires a change in design of the assay and approach in order to reproducibly identify this residual disease in this context. So to summarize our talk today, it's important to recognize that the success of MRD testing in the clinical context relies on collaboration of a cross-functional team of people. There are multiple components to this testing, from obtaining the sample to transport of the sample to performing of the assay and then reporting back to the treating providers. The oncologists play an important role in this MRD testing process by helping to determine when sampling is going to be performed. What is the timing to order the testing appropriately, to actually perform the procedure itself, and then to receive the information and monitor the MRD status and incorporate that into their medical decision-making. The pathologists on the right have an important role as well, because they're actually going to be receiving the samples into the laboratory, conducting the MRD test, using guidelines for testing, and using validated assays that are sufficiently informative to do a consistently high-quality job by understanding the challenges and special considerations of these particular types of assays. They also play a key role in reviewing the data and interpreting the results, and then conveying those back to the treating physician in a report that is sufficiently concise and informative that it can be used by the oncologist to drive their clinical decision making. So it's a team effort. So to conclude, what we can say is that MRD is a strong prognostic indicator in B lymphoblastic leukemia, or BALL, and is increasingly used to guide risk stratification and treatment planning. The optimal type of sample to submit for MRD assessment is the first pull of bone marrow of a relatively small volume, less than 3 mL of bone marrow aspirate. Standardized flow-based MRD assessment can be performed to detect leukemic cells down to a level reproducibly of 0.01%, and with somewhat improved assays down to a level of 0.001%, as is increasingly being advocated for. However, using flow cytometry for MRD testing can be challenging. It's technically a little bit complex and requires sufficiently trained individuals to both perform the assay as well as to interpret the data that is generated. And as a result, still requires some work to standardize this between laboratories. But increasingly, the MRD testing that's performed and the information that's provided is being used to guide clinical decision making. And so MRD testing is becoming a critical component of the treatment planning for patients with B lymphoblastic leukemia. With that, I'd like to thank you very much for your attention and be happy to take any questions.
Dr. Wood, thank you so much. That was a wonderful lecture, both in clarity and in scope. It's certainly a masterpiece, and we'll look forward to reviewing that. Now I'll let you catch your breath very briefly, and then we'll delve into an enormous number of questions. We'll try to get as many answered as we possibly can. You talked about the draw of less than 3 mL for the first pull bone marrow aspirate. Several people asked and remarked it can be quite difficult because the bone marrow tends to flow quickly into the syringe. Do you have any techniques that you know about or might recommend? For example, what size syringe would you use for procurement, or any other tips?
I mean, I don't personally perform bone marrow aspirates, so this has typically been done by the team, particularly the providers and the nurses and oncologists doing this test. So my ability to talk about the specific technical details is somewhat more limited. But in general, one typically uses a syringe, and you can control the amount of aspirate that is generated by the amount of suction that's provided on the syringe. And so I haven't heard before that it's difficult to limit the amount of material that's generated. Usually the problems I hear about are more that people want to pull too much volume, and people will pull up to 10 or 20 mLs of, quotes, marrow that actually represents to a large degree peripheral blood. But a lot of it is just a matter of using a relatively small syringe, like a 5 mL or maybe 10 mL syringe, and just carefully controlling the suction in order to minimize the volume that's initially aspirated.
Very good. Go ahead.
Another typical challenge that goes along with these types of samples is just everyone wants the first pull for whatever it is they're doing, whether it's morphology flow, cytogenetics, or whatever. And so it's important to come to an agreement among individuals that really MRD testing is what's most critical at these post-therapy time points, and to advocate for the use of that first pull.
Thank you very much. Thank you very much. Would you care to comment about which specific aberrant markers are the most helpful for distinguishing normal hematogones versus leukemic lymphoblasts in your experience?
Yeah, so that's a complex subject, and it's difficult to discuss that about individual markers in isolation, because these are typically combined together, and it's the interrelationship between the markers that provides a lot of the specificity. But antigens which are commonly aberrantly expressed in BALL, CD38 historically is one of these. A large fraction of cases, more than 50%, show downregulation of CD38, either partially or completely. And coupled particularly with CD10, which is often overexpressed in BALL, can be used quite effectively to identify MRD in a significant number of cases. Other common types of abnormalities include downregulation of CD45, which is typically seen in pediatric patients more than adults, but can be very useful by itself. Even CD19 itself is very commonly aberrantly regulated, often overexpressed in patients with BALL once one recognizes that often the normal counterpart for ALL is the first stage of hematogone development, or stage 1 hematogones, where CD19 expression is normally relatively low. And there are increasing numbers of other antigens that have been described. But historically, these are antigens that are relatively commonly aberrant and should be included in essentially any panel of reagents.
Thank you very much. Could you speak briefly about the use of peripheral blood for this sort of testing, and then also in particular any rejection criteria that are based on hemodilution values?
Sure. Peripheral blood in BALL is of increasing interest, in part because people want to spare patients the trauma of obtaining a bone marrow aspirate, and so hope that peripheral blood could be used as a surrogate for marrow. And there have been some studies performed looking at flow cytometry versus PCR-based methods, and now more recently against NGS, that show that indeed in patients post-therapy, there can be some leukemic cells out in peripheral blood, but the number that are out in peripheral blood is typically significantly lower than what's seen in bone marrow, because B-cell precursors normally are produced in bone marrow and don't really circulate in the blood to as large a degree. And so at the present time, bone marrow is still advocated as the primary place to enumerate the disease burden for MRD testing. But that isn't to say that going forward, peripheral blood may not play a larger role, in that we may be able to use peripheral blood post-therapy to screen patients for the persistence of disease, not for quantitation, but just the presence or absence, and then only go to the marrow at time points where it looks like disease is present and the need for enumeration then becomes justified. So it's an evolving area in terms of peripheral blood, but at the moment I wouldn't say that, at least for enumeration, peripheral blood is equivalent to marrow, even though it often is present there and can be detected.
Very good.
In terms of using hemodilution information to qualify samples, typically we don't exclude samples based on these types of quality indicators. We essentially run whatever comes into the laboratory, but then qualify the results based on the quality of the data that's then produced. And so one can run the sample, assess for the degree of hemodilution, and there are a few different schemes for doing that, but a relatively more useful one, I would say, is to look for the relative fraction of mature neutrophils. CD16 is often used for that purpose, of total neutrophilic lineage cells, to determine the degree of hemodilution and to kind of grade it into mild, moderate, or marked based on the frequency. And kind of bins that have been suggested would be less than 30% neutrophils would be considered mild or relatively normal. 30 to 60% would be considered moderate, and more than 60% neutrophils would be considered marked, and is more likely to reflect increasingly just peripheral blood.
Very good. Thank you very much. Now, just give us, if you will, a bit of a sense of this ramping up or demand for MRD testing as you've experienced, let's say, within the last 5 years or 10 years. Is it on a very, very sharp rise, or has it been, you characterize what the demand has been like in recent years?
I mean, demand over the last 10 years has increased quite dramatically. 10 years or so ago, it was recognized that MRD testing was likely to be important and was certainly being done routinely on clinical trials, but hadn't kind of penetrated to the extent that folks that were not on clinical trials were routinely asking for MRD testing. And that's changed fairly dramatically, in that now essentially most patients, if not all patients that are being treated for ALL, it's recognized that MRD testing is important and is being requested. And so the volume of MRD testing in the clinical laboratory has really escalated quite dramatically over the last decade, I would say.
Thank you very much. The last question I wanted to pose to you, Dr. Wood, was, would you say that MRD by flow cytometry is always needed because it helps identify the phenotype of the malignant cells, something which neither PCR nor NGS can provide at the current time? Is that a fair statement?
Well, every technology has its benefits and its limitations, and really these need to be used together in an appropriate context to answer a specific question. So it depends on the question that you're trying to answer. One of the values in flow cytometry, aside from its speed, is that it does provide immunophenotypic information. And in an era of immunotherapy, identification of the presence or absence of an immunophenotypic target can be of some value. So for instance, it may be, as data is increasingly suggesting, that the presence or the level of expression of either CD19 or CD22 is associated with the degree of response that's seen with targeted immunotherapies against those particular molecules. That's something that is not provided by molecular testing, and so these immunophenotypic approaches continue to have value in answering that type of question.
Thank you very much. And with that, I'm going to give you the last word with that answer. Let me now begin to sum up, and I'll do that principally by thanking so many people. First, of course, I want to thank Dr. Brent Wood of USC and the Children's Hospital of Los Angeles for a wonderful presentation today. Very enlightening, with lots of rich data and thoughts that we can all share in our laboratories, and worth going over again once we get it back on the website of CAP Today Online in a few weeks, slides and audio. I also, of course, want to thank Amgen for their sponsorship of this important program. As you can see, it's very important, and the importance is increasing, as Dr. Wood said, rather dramatically. Finally, I want to thank all of you who've taken time from your very busy schedules in your laboratories to join us today for this very special program. We're very grateful when you can take the time, and we really enjoy bringing them to you. And so with that, I want to sum up and thank once again Dr. Wood. I want to thank Amgen, and I want to thank all of you for participating in today's CAP Today webinar. And with that, I'll bring today's program to a close. Thank you.